So he had adequate bone. You can see he had pretty good keratinized tissue as well. A little deficient in terms of the premaxilla. You can see the anterior segment there. He has some deficiency there. And we can see that clinically as well as radiographically and from our CBCT. And so here's our lateral view and another, I guess, issue that we had to deal with was his jaw relationship. He was a skeletal class 3, and his fixed prosthesis that he was wearing was in a class 3 relationship, meaning he was in a they restored him with a severe underbite. I don't have the pictures here. I apologize for that, but he was in a severe underbite, and so our final restorative plan was to how do we provide him with the restorations that's going to give him function as well as some aesthetics as well. And with these types of patients, we know that we need something that's also going to give us that lip support. And so a traditional FP1 type prosthesis, a fixed bridge prosthesis, was probably not going to be the best option for this patient. If anything, he needed that lip support, so some type of a hybrid or a screw retained restoration that's going to give him the lip support was something that we felt was going to be the best in the long term, as well as understanding some of the other limitations that we're faced with. Another view just showing you the class 3 skeletal relationship between his maxillary and mandibular jaws. This is after healing, and again you can see his mandibular arch dentition there is failing as well. So that's going to be treatment plan for another time. But understanding that we're going to treatment plan him to be able to have implants with a screw retained restoration that's going to also give him that lip support that he so needs. And so we see here we have adequate healed ridges, healed ridge with a pretty decent amount of keratinized tissue. So that should trigger to us that this may be a case where maybe we can do this as a flapless approach. And looking at this occlusal view, you can see, having adequate keratinized tissue really, I think, gave us the affordability to be able to do this as a flapless approach because he had such good keratinized tissue. And so that's the way we approach this case, understanding that we're going to treat this as a flapless guided surgical case on 6 implants. So it's going to be an all on 6 type of prosthesis with a screw retained restoration, giving us the lip support, but also giving us retrievability and giving us adequate foundation by having 6 implants placed in the maxilla. And so for the next part of this presentation, what I want to do is I want to walk you through an actual VIP session. So you're going to actually hear me collaborating with the representative who's going to be walking through the whole planning process. And so this VIP session, what that is a virtual implant planning session. And we're doing this case with Implant Concierge. So Implant Concierge is the company that's working together with Zimmer, and they make the surgical guides. They'll make the provisionals. So we'll do all the planning with Implant Concierge. And so with some of these other companies, you have to do the planning. You have to buy the software. You have to, check the bone, place the implants, and so forth. This really simplifies the whole planning process. And so basically, what you're doing with the representative, with the person is you're going to walk through the whole protocol in terms of planning the case, where you want your implants, what size implants you want, angulation of implants, understanding that it's going to be restoratively driven, right? So, what's the final prosthesis? That's where we begin, right? So we have to understand that we need to begin with the end in mind. And so as we go through this VIP session, you're going to hear us having this conversation, right? How does this look? How does that look? What's the overall plan, right? So are the implants spaced far enough away from each other? Are they too close to each other? So that's all within the virtual implant planning session. And so that's all done remote, very easy, very efficient. And ultimately, this really saves a lot of time and saves a lot of potential complications when we're doing the actual surgical and the restorative later on.
So we have. I'll start by
close to each
asking
other.
Dr.
So that's
Kim, what's
all
the
within the
restorative?
virtual
What's
implant
the
planning
the, the
session.
final
And so that's all
prosthesis
done
going to
remote.
be for this case?
So it's going to be a fixed retrievable, a screw retained restoration. I guess somewhat like a hybrid or a FP3 type prosthesis. Um,
Okay.
the
Okay.
patient is in a class 3 jaw relationship, so I know it's going to be a little challenging, but we want to see if we can get at least even as close to, if we have to an edge to edge type of occlusion. So,
Okay.
and with that respect, we want to be able to give him some lip support with the prosthesis as well. So it's going to be a screw retained. That's what we're aiming
Okay.
for.
Okay. When we're in the process of fabricating or planning for the provisional, we'll probably do another short session with one of our designers.
Okay,
We do have the opposing model, so we can look at, the bite and how you want that relationship, and we can make modifications at that point. So
great.
that's all good information. Now, as far as the spread that you see just by looking at that occlusal 3D rendering, does that seem okay? It looks like we're close to first molars on both sides.
That does look okay. Yeah.
Okay, okay. So I'll go ahead and start with site. This is actually site number 3. I'm going to call this site number 3.
Okay.
And then let's go ahead and I'm going to increase the cross sections here so you can see a little bit closer. I'll start by measuring our restorative space. From the platform, I'm going to go to the acrylic there. It's about 11 millimeters. If I go to the occlusal table, we get closer to about 13 millimeters, or so.
Okay. That's
Is
okay.
that
That's
appropriate for
adequate.
your? Okay, perfect.
Yeah.
This is a 3.7 diameter implant by 10, and I'm going to go ahead and rotate. So if you notice on the cross sections, I would say at the collar on the palatal side, it seemed like we're just right there. If I had the opportunity to countersink the implant a little bit, it would
Yes.
cover that area, but then we're going to probably go into a little bump. So do you rather me leave it there where we have it?
I think so, but can we increase the diameter? Give it let's see, a 4.7 diameter implant. See what that looks like.
Yes, sir. Absolutely. There's the 4.7 now. Yeah, I think the 4.7.
I think that'll
I'm going to
hold.
give you a quick measurement here. We're close to almost 2 millimeters there on the buckle, so that looks really good.
Yep. That's fine.
Okay. Okay, so that's a 4.7 by 10. That looks really good there. And I can bring that sleeve probably a little bit closer to the platform. Have you use the 19 millimeter prolongation? That seem okay there?
Yes, it does.
Okay. I'm going to move on to site number 6. Let me go back and make sure on that occlusal view that looks okay. I'm going to remove the pins for now so we can just concentrate on our implants here. So site number 6, right now I have a 3.7 by 10. If you look at the axial view on the top right screen, as we go mesial, you see how it gets a
Yes.
little bit thinner. So where we have it, seems like we have, better width. I'm going to go back here and I'm going to measure our restorative space, make sure this is adequate here, about almost 15 millimeters or so.
Mm-hmm. It looks a little more
Um,
sunk than the previous.
it does, however, look at the line, the green line representing
Yes.
the platform. We're at almost the same level, so I can bring it a little bit more coronal if you prefer that, but we're
Um,
not going to be at the same level.
And so you can see how detailed we can get with a virtual implant planning session. And so, the representatives, they're all very experienced as well. So they understand uh, what it takes in terms of planning, what we're looking for. And actually, when you do a number of these cases and you work with the same representative, same technician, they know what you want. They know what you're looking for in terms of, say, bone dimensions. How far coronal apically you like your implants placed. And so we can get very detailed with the angulation, positioning, even to the types of implants that we like using. And so we can be very specific, and we need to be very specific with our planning because This is going to dictate the flow of our surgeries. Because if anything is off in our planning, it's going to be directly related and correlated to our surgeries. And so that's why it's critical when we go through this planning that we take our time and we really sit down and really evaluate each specific site, looking at every single dimension: apical coronal, mesial distal, buccal lingual, spacing between implants. Where is it in relation to the final prosthesis? So all of that comes into play, and that needs to be taken care of in the beginning. And understanding that it's the restorative prosthesis, the restorative design that's going to drive the surgery. Because once this is laid down, once this foundation is set, the surgical procedure itself is really not very complicated. We can be very, very easy, streamlined. Time management is very well adhered to, and it just makes the flow of everything fall into place. So now we're going to segue into the surgical portion of this presentation, showing you how to use the guide to do our implant placements. And so here's the guide seated over the arch, and you can see it's actually a well-fitting guide, pretty stable even without any support that it's staying on this edentulous ridge. Notice from this photograph the amount of keratinized tissue that's showing through the holes, right? So you can see we have adequate keratinized tissue, and which is already known from the beginning that we can do this as a flapless approach. So making sure that we have good keratinized tissue that's going to allow us to do this procedure, this whole surgical procedure as a flapless approach. So now we're going to go to the video showing the live surgical portion of this presentation. And as you can see, I'm fitting in the surgical guide to see that it's seated adequately over the patient's arch. So being that this is a full arch case, we want to make sure that this is seated well, there's no rocking, so that way we can go ahead and then engage the anchor pins. Now, this case actually, we had to improvise along the way, because what happened was we were looking for our anchor pins, and somehow they had gotten misplaced, so I had to improvise. So what you're seeing here now is the preparation for the grafting procedure. And what I like doing is I like to make the BABE graft. And the BABE graft is the biologically activated bone enhanced graft complex, as you'll see later in the presentation after implant placement, how we do our augmentation procedure. So now we're doing the preparation for the anchoring pin preparations. You see we're using the drills that are included with the guide for the anchoring pins. But in this case, as I mentioned, we had misplaced them, so I had to improvise. And so what I used were some long piezo drills to do the preparation, and basically just use the drills itself to anchor and secure the surgical guide to the patient's arch. And you'll notice also that this is done flapless. We're doing this as a flapless approach. This is a mucosa-borne surgical guide. And for the most part, when we do full arch cases, I traditionally like to do flapless if I can. And so this has all been prepared in terms of whether we can do this as a flapless or a flapped approach, all determined basically dependent upon the amount of keratinized tissue we have. And if we have adequate keratinized tissue, we can certainly go ahead and plan for a flapless approach. And by doing this as a flapless approach, it makes it much more easier for not just the patient, for the clinician as well. We don't have to go ahead and raise these large flaps to expose the bone, but we can go ahead and secure our surgical guide and proceed with drilling. And so what we like to do is we like to engage 3 fixation points. So 3-point fixation to basically secure the surgical guide in place. And being that we had to improvise, for this case, I believe we only used 2 fixation pins, 2 anchoring pins to secure the denture. And you'll see, even without holding the surgical guide in place, we have pretty stable fit of the denture to the patient's edentulous ridge. And that's all dependent upon getting good models, taking good scans, so that we can have a nice fitting surgical guide. And many times we have to do that from the preliminary restorative planning to get a good surgical guide, making sure we have a nice fitting denture that will be duplicated for the surgical guide. And so what you're seeing here now is the BABE graft, right? So this is particulate graft material that we've impregnated with the patient's blood using his growth factors and stem cells so that we can convert the particular graft material into this putty complex. So what we're going to do with this is after we perform our implant placements, we're going to augment the anterior maxilla, the ridge there, because from our pre-planning workup, we noticed that there was a little bit of deficiency in terms of the alveolar bone in the premaxilla. So we knew we were going to go ahead and graft um, the maxilla segment after we do our implant placement. And so what we're doing now is you see we're using a tissue punch to basically mark out our osteotomy sites. And sometimes if you don't have a long enough tissue punch, you can use basically your burr, a round burr, or any type of mark to be able to just initiate your initial osteotomy. So one way of doing this is to go ahead and remove the tissue plugs after you do a tissue punch, or you can go ahead and proceed with your osteotomy preparation as a flapless, going straight through the tissue, which is what we did here. And so you can see the tube adapters that's being fitted and verified in terms of engagement into the surgical guide. And basically, as we mentioned and showed you earlier, basically it's a step-by-step cookbook. You know, the protocol drilling sequence, we're just going to follow each drilling protocol according to what's been planned. And so I still have my assistant secure the surgical guide, just hold it in place so we don't have too much movement. And then basically, depending on the sequence, I have another assistant who will transfer the tube adapters to me with the appropriate drill. And so everything is done in sequential manner, meaning everything is done in sequence according to the protocol sheet. Because the protocol sheet's been pretty much laid out according to each osteotomy site with its respective drilling sequence, so that you don't have to do any thinking. So everything's been already pre-planned. And so these are the advantages of doing these guided cases where everything's being pre-planned prior to the surgery. So we know exactly which drills we're using. We know exactly which steps we're taking in terms of osteotomy preparation. And so when we do our initial drilling, what I like to do is, just to make sure that we removed any soft tissue, right? So if we didn't remove the plugs and we're just drilling through the tissue, we can go ahead. I'm just verifying and engaging that there's no soft tissue remaining in the osteotomy preparation. So, and I'm just checking the bone as well. So I like to just check everything, even with the guide in place. And we have that flexibility, because we have this secured um, in the patient's arch. And so you can see we're doing our implant placement, and we can do our implant placement directly through the surgical guide. And so that's one of the unique features of doing this flapless and doing this as a guided approach is everything is planned from the osteotomy preparation all the way through implant placement. And then at this point, we can even leave that fixture in place to give us another anchor in terms of fixation. So you can see we have the two anchoring pins that are secured on the fascia, but the initial implant placement can also be used as another source of anchoring security. So we can do that, and then we can go ahead and proceed with the subsequent drilling for the remaining osteotomy sites. And so again, everything is done according to the cookbook protocol and just in sequence, with good irrigation, with good stability of the surgical guide over the patient's arch, and basically just one after another, just following along the surgical protocol. And so it takes all the guesswork out of our surgical procedure, which makes it much more beneficial for both the patient and the clinician. It's much more comfortable for the patient because there's going to be less swelling, less postoperative pain, and just an overall much better, much more comfortable experience for the patient. And for the clinician that's performing the surgery as well, everything is so streamlined, everything is so sequential that there's no guesswork, right? So everything just flows. And so in actuality, it will actually reduce the overall treatment time, the overall surgical time that we're actually spending. And the benefits of not having to spend as much time doing surgery, we can spend time with seeing other patients as well. So it makes it more time efficient, cost efficient, and just overall just a much more uh, pleasant experience in terms of performing these types of surgeries. And so everything I do, I like to do everything in sequence, going from one ostomy to another. And if it's using the same drills, I'll just go from one site to the next site. And so, you can do these individually per site, meaning you can do your sequential drilling per each osteotomy site, or if you know that you're going to be using sequential drills for each subsequent osteotomy site, you can go to each site to do your drilling. And so that's why you see minimal bleeding as well. So not a whole lot of bleeding because we didn't raise a large flap, right? By doing this as a flapless approach, again, it makes the surgical experience much more easier because we don't have to deal with all the blood that's being exuded from the surgical sites. And also for the patient as well, as I mentioned earlier, it's a much more comfortable post-operative experience for the patient because we didn't raise any large flaps. And sometimes what I do is, if you have noticed on the drills, we have some of the blood that's being, some of the bone that's being harvested from the osteotomy preparation. I try to save that bone that's being that's been attached on the drills. So I'll use that in cases of where we do have to do some augmentation. I can use the patient's autogenous bone to be able to mix with our particular graft material as well. So I try to save as much of that particular bone that's being harvested from the osteotomy drilling so that I can use that for potential grafting in the later sites. So you can see everything's in sequence. And usually I'll work with two assistants, one surgical assistant, and then another assistant who's going to be going through the protocol sheet with me, and we'll go through each site. So site number 3 is going to require XX tube adapter with XX drill. Site number 6 is going to require XX tube adapter with XX drill. So everything is done in sequence. And you can see how quickly it is. You can see I'm going from one site to another because I know that each site is going to use the same drill. I don't have to go and change out burrs. So for me, if I'm using the same drill for multiple osteotomy site preparations, I'll go ahead and just do each site at that specific drilling sequence. And so, we're always trying to, confirm and double check our sequence when we're doing our drilling. So my assistant will read and tell me which step we're at in terms of drilling sequence. And then we'll also anticipate whether or not we're using the same drill for, other osteotomy site drilling as well. And so you can see already, we're moving along and everything's actually just flowing pretty seamlessly, right? And again, you can see the blood, the bone that I'm able to pick up from the osteotomy preparation. And so you can see this surgical guide that's being held in place by the anchoring pins, it's nice and fixated, so we don't really have to worry about inaccuracies in terms of, are the implants going to be placed in the proper position? Because everything's been worked up, everything is nice and secure, we're pretty confident that implants are going to be placed in the proper position because we know we've worked everything up from planning all the way through to this part, the execution. Great. So now what we're going to do is we're going to go ahead and remove the guide, as you see in this video. We're going to remove the guide and we're going to really just kind of inspect where we are in terms of implant placement. We want to evaluate the soft tissue. And then, as I mentioned earlier before this, when we started the surgery, we can go ahead and use a tissue punch to actually go ahead and remove any remaining soft tissue that may be present, right? So just to verify that there's no soft tissue remnants, any tissue tags that may be within that osteotomy. So we want to verify, and just looking at the soft tissue, you can see very minimal bleeding, right? So we don't have a whole lot of bleeding, just very minimal bleedings, right, from the punch. But this patient, he had adequate keratinized tissue. He had a decent amount of keratinized tissue, which is one of the reasons why we had planned to do this as a flapless approach. So we're just going ahead and verify. Again, you want to verify adequate soft tissue, adequate keratinized tissue, right? So that's what we're also doing. We're just making sure that we don't have a lack of keratinized tissue. And again, that's been all pre-planned, and we knew that we can do this as a flapless approach because this was all part of the planning process. And so you saw me take a tissue punch, right? Just going into the osteotomy site, just removing any tissue, excess tissue, any tissue tags. I'm using some small rongeurs. And then I'm also evaluating the osteotomy preparation, taking my probe. I want to see how far below the soft tissue my crust of bone is, right? Where's the alveolar bone? How many millimeters below the soft tissue am I? And we did some preliminary measurements. Some of these implants are going to be actually placed subcrestally. Again, we're just going ahead, just each site, just making sure we remove all excess tissue. We're going to double check to see where our bony platform is in relation to the soft tissue thickness. And if I could have actually more tissue, I prefer to have more tissue than less tissue because I can always take tissue away. If I don't have enough tissue, that means then I have to do a separate procedure to build up the soft tissue. So if I can have a surplus, an abundance of soft tissue, I'd rather have that and take away tissue later than try to rebuild soft tissue um, later on. So again, just each site, you can see all the osteotomy preparations are nice and evenly spaced out. Again, just using small rongeurs to just remove any tissue tags. So I can use curettes to go into the osteotomy site to make sure that we have a good, clean site. And we're just doing this for each site. For 6 implants, doing this as a flapped approach, think about the amount of bleeding that we have. Think about the retraction that we need to maintain, right? So I may need two assistants, right? One surgical assistant, another surgical assistant to help with retraction, right? Those types of cases are difficult. They're much more involved to manage when you're doing full arch cases. And so, just think about the stress level for not just you as the surgeon, but the stress level with the assistants, right? They have their stress levels as well. And then also for the patient, right? Because, there's much more bleeding involved. There's more anesthesia that's involved, right? So patients are under much more stress. So those types of cases are cases that maybe, you'd want to do them under sedation, right? So, but, with these types of cases, time is much better managed. Post-operative pain is managed much more better. There's minimal swelling, right? So again, you can see I'm just giving him a little bit more local anesthesia because just to prepare for doing some soft hard tissue augmentation after implant placement. I just want to make sure that we have adequate anesthesia in those areas. So even within the osteotomy itself, I can go ahead and anesthetize and really inject right into the alveolar bone. Sometimes we have some areas that are a little bit more sensitive, and so what we'll do is we'll just give some anesthesia into the alveolar bone just to make the patients a little bit more comfortable. And we take our time. We're not rushing these cases. Even if we did this as a flapless approach, we're not rushing these types of cases. We want to make sure that we have a very good result because, once we have a good solid surgical foundation with implants, then we know that we can build our restoration with a solid foundation. Knowing that the long-term prognosis is going to be favorable. So it's always about managing not just the hard tissue but the soft tissue as well. So hard tissue and soft tissue management. And so with these types of all on six protocol cases where we do this as a flapless approach, we know that we can have a good long-term stable prosthesis that's going to be on these solid implants that we place for this patient. And so just each osteotomy preparation, just going back and just making sure we have good, clean sites so that way when we place our implants, we're not going to introduce any soft tissue tags into the osteotomy that may inhibit osseointegration, right? Because the last thing we want to do is get fibrous encapsulation of soft tissue so that way, possibly leading to some implant failures. And so it's always about trying to maximize success, right? And really minimizing some of these complications and some of these issues that may arise. And so, making sure that, understanding how do we manage those complications? How do we deal with some of those issues that may arise? So now we're going to get ready to do our implant placements. And with these types of cases, we have to be able to learn or be accommodating to improvise, right? So, for this case, we're going to go ahead and place our implants freehand. And so by having a little bit more experience, I felt comfortable by removing the guide and place our implants freehand. And so we're not changing any angulation, wherever the osteotomy preparation was made, that's where the implants are going to go. So that's where we know that we can get a very good stability of our implants, right? Because the osteotomies have been prepared all the way through. And so without the guide, I'm able to go ahead and place our implants in a proper position, exactly according to how the planning was pre-planned. And so you'll see from the photograph and the picture that's coming up, we have nice, good parallelism of all 6 implants. And, we can't really do that if we're doing this freehand, right? So that's another benefit. By doing this as a guided approach, we can ensure that we have good parallelism. And just looking at the picture, you see how parallel we have between our implants. So nice distribution of the implants, nice and spaced out, nice and parallel, right? So many times when we're doing these full arch cases, we can't do that doing it as a freehand. So now all the implants have been placed. Now that they've been placed, we'll go ahead and we'll remove the fixture mounts, as you see, as I'm doing here. So I go ahead and remove each fixture mount. Now, by doing this freehand, not through the guide, as I mentioned earlier, one of the issues is depth control. So we don't really know exactly how deep we are. And so basically, this part of the procedure, I'm going to do freehand. And after I remove all these fixture mounts, I will go ahead and bury and sink the implants a little bit more. And what we did was actually we went ahead and we had measured tissue height, right? Tissue depth. And that's what you saw me do when I went in with the probe to really measure how deep we were in terms of tissue height to the bone so that I know how much more I need to sink the implants. So that's what we're doing here. We're removing all the implants, and then manually we'll go ahead and um, we'll engage the implants so that we can sink it a little bit more, so that we're either at the crest or slightly subcrestal. That's traditionally what I like to do. So we'll go ahead. We'll sink the implants for each one depending on the measurements that we took before with regarding tissue height. Whether it was 2 millimeters or 3 millimeters, I'll go ahead and we'll sink the implants. And then ultimately, the way we verify it is we'll confirm with radiographs. We'll take some X-rays to verify parallelism. We'll take X-rays to see where we are in relation to anatomical structures, and then ultimately, really to verify where we are in relation to the alveolar crest, whether we're too supercrestal or even sometimes too subcrestal, right? So that may change. So when we did our initial planning, we've took all that into respect in terms of how deep we wanted to sink the implants, and especially with the two anterior implants in the premaxilla, I knew that I wanted to countersink a little bit more to compensate for the thin bone that we had presented with, because we're going to do some grafting there anyway. So that's what I'm doing here. We're just going ahead and we're taking our torque wrench and we're just engaging the implant. We're burying it a little bit more. And then we'll go ahead and we'll take some radiographs to verify how deep we are or how shallow we are. And again, I'm taking a probe to measure, to see where I am in relation to the alveolar bone. And basically, at this point, it's really just everything done freehand, done manually in terms of how deep I want to sink the implants, where I am in relation to the alveolar bone and soft tissue, and to see that I do have adequate soft tissue all around the implants. So that's what we're doing here. We're just going to go verify with some photographs, some radiographs, and that's what you see here. We're going to take some periapicals just to confirm our placement in terms of uh, implants with respect to each other and with respect to the bone. So that's what you see here. The assistants will go ahead and take individual periapicals. And then from there, we can go ahead and we can sink it more, or if we can bring it a little bit more to the crest if we need to, whatever adjustments we need to make. So that's why we always take radiographs, just to verify, so that, if we're near any anatomical structures, then, we want to confirm that as well. So no matter how experienced we are, we always want to double check, right? Because we can never be too safe, and we always want to make sure that we're always within yeah, the parameters to make sure that we are successful. And then we went ahead and placed some healing collars on. And so initially, when we did the pre-planning, the plan was to go ahead and try to load our implants with an immediate provisional. Um, but for this case, one, because we're going to graft, and then two, because posteriorly we didn't have quite enough initial stability, we opted to just go ahead and place healing collars, and then we would load the implants with a fixed provisional later on. And so what you're seeing me do here is we're doing some tunneling. We're going to do some grafting to graft the facial aspect of those anterior implants. And so basically we're doing something like a vista approach. We're going to do a vestibular access and tunnel into the alveolar bone so that we can graft through that tunnel. And one of the benefits of doing a tunnel procedure is, again, we don't have to raise large flaps, because ultimately when we raise large flaps, there's risk for more complications, more bone loss, more risk of failure, and so forth. So we want to try and be as minimally invasive, right? So you hear that trend today, minimally invasive surgery, a little bit of an oxymoron, but we're trying to minimize the potential complications. And by doing some bone grafting minimally invasively, we can ultimately minimize any potential complications in the future. So that's what you see me doing here. We're doing some tunneling access, right? So making a couple of vertical incisions, and then we'll access through the mucosa down to the bone. And I'm doing this full thickness, right? So I'm going down all the way down to bone, and I already prepared my Bay graft, the bone graft, right? Also known as the sticky bone, right? And we're gonna go ahead and we'll tunnel in our bone graft after we do our elevation. And so when we go and do our tunnel access elevation, you got to make sure, especially if you're doing some augmentation procedure in premaxilla, that we get at least over the alveolar crest, right? So you see me tunneling the facial aspect of where the bone is, but as I'm tunneling, I'm also engaging and trying to engage towards the palatal, right? So that we can really tunnel and pack our bone and condense it to where the implants are placed. And ultimately, when we did our CBCT, we realized that the bone being a little bit thinner on the facial, in order to prevent any potential bone loss in the future, because we know, ultimately from studies that's been conducted, that we want to have at least 2 millimeters of bone on the fascia of that implant. And so, because we were at a disadvantage of having less than 2 millimeters after we planned the case, that's where we plan to augment it. And so we proceeded to do this VISTA approach, tunneling technique, to try and be as minimally invasive as we can. So that's what you see me doing. So it's a full thickness flap, periosteal down to the bone, releasing the soft tissue, right? But also, just taking our time so that we don't tear the soft tissue. And we're using these thin blades to be able to access the tunnel, so that way we can go ahead and introduce our graft material into the tunnel. And then we're also going to be utilizing platelet-rich fiber and PRF membranes to help with the healing and for the regeneration. So, the literature has been controversial in terms of the benefits of platelet-rich fibrin, but I've been using this for about, 5-6 years now. And for me, the results that I've seen, I think it's an added benefit. As controversial as it may be, some say it may be only anecdotal, but I mean, from the results that I've seen, from the pain management, swelling management, from the patient's perspective, I think it's been beneficial and advantageous to incorporate and use platelet-rich fibrin. So I've done a couple webinars in the past regarding the Babe graft using the sticky bone concept and platelet-rich fibrin, and I think certainly we have much more advantages and benefits than not using it. So by using this technique, we can be as minimally invasive as we can, and yet trying to maximize the potential for not just soft tissue but hard tissue as well, right? So that's what we're doing here. So we're just tunneling anteriorly. We're tunneling a little bit to the posterior. Probably, I guess, if you consider maybe lateral incisor to lateral incisor, because that's where we had a little bit of deficiency of alveolar bone. So that's what we're doing there. And so now we're going to get ready to introduce our bone graft. So that's actually autogenous bone. Remember, we took shavings from the drill bits. As I mentioned earlier, I mentioned that we can use that autogenous bone. So there's our Babe graft, there's our sticky bone, right? That was particulate. So there's our autogenous bone, and I'm going to mix the two. And, I like using autogenous bone. That's why I call it the Babe graft, because we're actually activating that bone graft with biologics, with using not just the patient's blood and the stem cells and growth factors, but using the patient's own bone, right, autogenous bone. And by using the patient's autogenous bone, we can utilize the BMPs that's associated with the autogenous bone to help with the healing and maturation. So that's autogenous bone that I'm going to introduce first, right? So I like using the autogenous bone first, and then we'll go ahead and introduce the secondary graft, the Babe graft, over the autogenous bone. So traditionally, similar to Homely Wang's, like the sandwich technique that he talks about, but I like to use the autogenous bone first, and then the particulate graft second, and then go ahead and use our platelet-rich fibrin membranes. So we're going to go ahead. We've isolated, we've reflected the soft tissue underneath. We were able to access the tunnel by releasing the soft tissue away from the bone. Remember, it was a full thickness. We're going to go ahead and introduce our graft material, right? And again, I'm using the autogenous bone first, right? There's the autogenous bone. We'll tunnel that in, and then we'll pack it with the particulate graft afterwards. And so that's what you see here. All right, so there's my autogenous bone. We'll place that with our instruments. Because we made a minimally invasive access, it's a very small incision, maybe 5-6 millimeters wide. So we're just reflecting that, and it's been released underneath. So we're able to kind of retract that tissue fairly easily. And then because we're able to incorporate the growth factors and the patient's blood to make our sticky bone and our platelet-rich fibrin, a lot of the graft material is not really being lost. As you can see, I could pack it in. And that's one of the benefits, the handling capabilities of that particulate graft material. So what you're seeing here is the Bay graft's particulate graft material that I'm able to kind of tunnel in. And so we're going to just keep tunneling in the graft material to try and plump up and expand that ridge, not expand, I'm sorry, to be able to increase the width of that alveolar bone there. So I'm just tunneling, we're packing and really condensing it, and we're going to do this from both sides. So I'm doing it from either side to really just be able to maximize the amount of bone that I can introduce into that area. And again, I'm always trying to over engineer our cases. I want to maximize, and the more bone I have, the more comfortable I will feel in the long term. And so if I can harvest bone, and if I can graft and gain, say, at least 3-4 millimeters of bone on the facial, then I know for long term that's going to maximize not just stability and function, but the aesthetics as well. So that's what we're hoping to do. So I want to, and also to be able to count for any potential resorption. There's always going to be a little bit of resorption, dieback from our grafting procedures, but I want to be able to maximize the potential by over engineering our cases. So now I'm using a bone condenser to really just to densify and condense the bone. And again, we have the growth factors, we have the cytokines that's going to initiate and speed up the healing not just for the soft tissue but for hard tissue as well. So I'm a big firm believer in the growth factors and cytokines and stem cells, using this with the bone graft material. So I do this for practically all of our grafting cases, whether it's ridge augmentations for sockets, sinuses. It's been definitely a positive in terms of how I manage my grafting cases. So this makes it very easy. It's very clean. You can see it's not messy. I'm not wasting a lot of graft material on the outside. A lot of times when you're using particulate graft material, those small particles, they get washed away with the blood, right? How many times have you tried to pack an area, and once the saliva or the blood gets hydrated into the particulate graft material, a lot of it just kind of dissipates and washes away. When we use this technique, it's very well contained. It's almost like a putty block, right? So that's why the handling is just makes it so much easier. And so when we know that we have enough bone, then basically after that it's just closure. We'll just put in some, either I like using monofilament polypropylene sutures, either 5-0 or 6-0 polypropylene sutures, just to close the area. So it's very minimally invasive, very atraumatic to the patient, right? Less traumatic than as opposed to if we were doing a full thickness flap when we're doing our large flat releases, right? Then what do we need to do? We need to try and get primary closure. So that means we need to go and do some periosteal releases. And so when that happens, then we know there's much more inflammation, there's more pain involved, and just overall, it's just a much more uncomfortable experience for the patients. But when we're able to do these minimally invasively, it's a much more easier, much more comfortable procedure for our patients. And so that's why I try to maximize the benefits by utilizing different procedures, different techniques. And I think by using the Babe graft and using tunneling access procedures, this definitely helps minimize some of those potential complications and potential post-operative sequelae from doing those surgical procedures, because it is a surgical procedure. So we're just continuing just to graft. Remember, I made 2 vertical incisions on either side. So I'm tunneling using both sides for the access. So I want to be able to maximize the amount of graft that I can graft to those sockets, not sockets, I'm sorry, the alveolar ridge. So that's what you're seeing here. And so we continue to do that until we're ready to do simple closure. So once we've packed all of our bone and we feel that we have adequate width, now you're going to see me introduce the PRF membrane. Here's our PRF membrane. And so we'll introduce that into the tunnel. And again, just kind of using that as a barrier, but not necessarily acting as a barrier. So I'm using the PRF membranes to help with the soft tissue healing. It's going to actually lay over the bone graft that we tunneled into the area. So I've made what, maybe three, four of those membranes. So I'll go ahead and we'll just go ahead and pack each one of those into the tunnel, just accessing it from our remote incisions. So we'll just go ahead and multiple layers, just two, three, four layers. And then after that's completed, then we just go to closure. So that's what you see here. So we're using, again, as I mentioned, polypropylene. This was, I think, a 5.0 polypropylene suture that I'm going to use. And I've been using actually more of the polypropylene sutures, a little bit better in terms of healing and maintaining the closure with polypropylene, I felt. So I like using polypropylene in a lot of my surgical cases, especially when you're doing like these, say, perioplastic surgery cases. So we're just doing our final suturing because this was minimally invasively done. Two small remote incisions and just a couple of sutures for closure. And so you can see how easy the procedure can be and how neat and clean the procedure can be without having to raise large flaps, having to try to achieve primary closure. So this is just another way, another technique of being able to augment this ridge by using this procedure and this technique. And so understanding, from the pre-planning process, from the pre-planning sessions, that we were able to, plan accordingly, knowing that, we had some adequate bone, but not quite enough, and that we want to do some augmentation. So that's we approached it from a tunneling uh, technique with some minimally invasive remote incisions, grafted using PRF technology. And then here's our final picture. So a couple sutures, we augmented the premaxilla there. We did some tunneling grafting. Here's our healing collars placed. You can see we were able to bulk out the ridge, the alveolar ridge there in the facial of those anterior implants. But you can see well keratinized tissue, right? And here's our radiographs, final radiographs, nice and parallel, right? Nice and parallel placement of the implants. Posteriorly, right, just right at the sinus floor. Here's a panoramic, just showing you placement of those implants. Nice and well placed, spaced out evenly within each other, not invading the sinuses. Here's our CBCT cross sectionals. Now that area you see is from the tunneling graft that we did. Now, mind you, none of the implants were exposed when we did the flap elevation, right? So here's some more grafting, right? You can see that's all grafted material on the facial. And remember, I over-engineered, I overbuilt, I added more than I need to compensate for any resorption. You can see well placement within the alveolar bone. This is implant placement in the posterior. And then you can see coming up another slice, right? Again, implant placed right before below the floor of the sinus. Adequate bone on the facial. We have at least 2.5 millimeters of bone on the facial around that implant. And again here, right, just right at the floor of the sinus. So you could see the benefits and advantages by doing this all guided, having direct control of implant placement. And so now that the implant's in place, the next step would have been to go ahead and provisionize. And so again, what you're seeing here, this is now a PMMA provisional that was pre-planned and pre-made to the surgery. And so ideally, what we would have liked to have done was to provisionalize and load the implants at the time of implant placement. And so, but we had this ready to go so that in case that we were able to, we wanted to provisionalize at the time of surgery. But again, as I mentioned earlier, in those cases where we can't provisionalize, or we run into some issues or complications, we need to understand how to manage those cases. And so for this patient, for this specific case, because we didn't have the primary stability that we wanted, we decided to just go ahead and place implants with some healing collars, and we're going to let him use his dentures for a little while, and then we'll convert him to this provisional before we go to final prosthesis. And so with this view, you're seeing the cutouts of how this is going to seat over the guide. And so now what we can do is we can actually stack this over our surgical guide, and you can see where the anchor screws would be engaging, and then this would seat over, we placed directly over the guide, where the guide was in a proper position, and those cutouts would be where the temporary cylinders would be coming through, so that we can pick up the cylinders with this provisional. And so here, once we're able to verify seat and verify the position, the anchor pin slots, those will get cut off afterwards. So we can just cut that off. We can polish it. We can smooth down the provisional, and then convert this to a screw retained provisional. And so what you're seeing here is we're trying this in the patient's mouth. You can see we needed to do some adjustments. That was the second reason why we didn't want to load this. So primary reason for not loading this right away was because of primary stability. Secondary reason was because of the occlusion was a little bit off, because for this patient, because he was lacking posterior teeth in the mandibular arch, we weren't able to quite line up the maxilla and mandibular arches in terms of provisionalization. So from here, now what I can do is I can go ahead and tweak and adjust the temporary, so that way when he's ready to be loaded, when the implants are ready to be loaded, I'll have a provisional that's going to be in a much better ideal position, with a tooth set up in a proper position as well. And so we're seeing patient inocclusion, but I understand some of the limitations in terms of what I need to adjust. And so we can take care of that now while he's in the healing phase during this implant integration time. And so we've seen the benefits of what guided surgery can do for us clinicians, not just restoratively, but surgically as well. And so really the next phase would be the restorative aspect. And so, due to limits of time, we couldn't show everything here, but the next next phase would be going through the prosthetics, the conversion, right? So after healing, we can go ahead and we can transfer that provisional to the patient, and then take that provisional and work up all the records in terms of leading towards the final restoration. So I hope I was able to share a little bit about guided surgery, the benefits of it. Just being able to see a procedure in action, I think goes a long way, as opposed to just seeing a PowerPoint presentation. But I'm hopeful that going forward, that you can start learning and incorporating some of the benefits of what guided surgery can do. So I'll be around after the presentation to take any questions, comments, and I thank you for the opportunity. And thank Zimmer also for giving me the opportunity to present some of my cases. Thank you.
Thank you, Dr. Kim. That was a really great presentation. Really enjoyed it. I'm sure everyone else did as well.
Oh, you're welcome.
I think we have some really great questions from the audience. So is it okay if we get to those?
Oh, absolutely. Absolutely. This has actually been a fun topic. So, I really enjoy doing these types of cases, and hopefully just share some of my experiences.
Oh, it's great. Great. Sharing a lot of knowledge with everyone. So I know we all really appreciate it. So thank you. So I believe the first question came in, and I believe you pretty much answered this at the end, but by looking at the mandible occlusion, does it limit the max plane of occlusion?
Absolutely. So, he is going to go ahead and restore his mandibular arch shortly. So we took all that into consideration, especially when dealing with the final restoration. But we definitely have to take that into consideration, not having mandibular posterior teeth, trying to get the occlusal plane where we want it. So we definitely have to take that into consideration, and was taken into consideration when we did our planning. So yes, it was, and it is, and it will be.
And the second part of that question, I believe, the question was asked before they saw the denture, but it said, why not use a method of doing a temporary denture over denture for the occlusion?
Yeah.
But
Yeah,
you did
absolutely. We can do that. We can certainly use a denture, and a lot of times when we're doing these types of cases, especially full arch cases, we kind of do have to go back to our removal prosthetic principles in terms of denture design, getting the occlusion, getting the vertical. So we do definitely utilize our removable principles, and that has to be taken into consideration. So, but we certainly can use a removable. try to limit using removable appliances if I can, just because, especially in this case where we did some grafting, to try and minimize some of the pressure in those areas. So, hope that answered the question.
Great. Yes, thank you so much. Let's see here. I don't believe they asked if N-code abutments were used, but I don't believe they were for this
They
case.
were not. They were not, but I can transition to encode abutments a little bit later. So that's
Okay.
the plan. So that way I can kind of keep this um, digital in terms of, restorative and maximizing the uses of the encode abutments. So I like using encode abutments just because it acts as a scanning body. It acts as a healing collar. So yeah, I'm going to certainly transition them into encodes, so that way I can minimize, some of the other um, principles in terms of impression taking and so forth. So, I could have done it from the beginning, but in this case, I didn't. But certainly, we can plan to use encoded healing abutments for any type of restorative case.
Perfect. Thank you. Let's see. Can you give more info on the tissue glue that you used?
The tissue glue, the cyanoacrylate, the pericryl.
Possibly,
Maybe?
yes. They
So,
refer to it as the tissue glue, but
right.
I'm assuming what you're saying is
So the
correct.
tissue
Yes.
glue, right? So it's it's kind of like a biologic crazy glue, periacryl. It's a cyanoacrylate. I use it quite often, especially whenever I'm doing grafting cases, soft tissue procedures. It really kind of gives it this a sealed layer over the surgical area. Kind of giving it a little protective barrier over sutures and so forth. So it's called periacryl. It's cyanoacrylate, and most of the supply companies they'll sell that. Yeah, so it's a nice little um, adjunct to use when I do surgeries.
Perfect. Thank you.
Mm-hmm.
Let's see. How well do you need to understand CBCT to initiate planning?
Well, yeah, so we really do need to have a CBCT, especially when we're planning our guided cases. That's one of the benefits of working with Implant Concierge. You can have that VIP session that was shown in the video, where you can really sit down and go over the case and really analyze three-dimensionally with the representative. And so even if you're not really familiar with how to navigate through a CBCT, they can guide the case, they can guide you and help you. So to answer the question, you don't need a lot of information or a lot of uh, knowledge about it, but certainly having some basic ideas and concepts will help navigate through the case. And certainly working with other colleagues and other referrals and partners like Implant Concierge, we can gain a lot of information by having having a CBCT that's well read.
Great. Perfect. Thank you so much. Jumping back quick to the pericryl.
Periacryl, yep.
Pericryl. They asked if did you mix it with your graft?
Oh, no. So the periacryl I don't. So periacryl after the surgical procedure over suture lines is where I'll place a couple of drops. It's a liquid. It's like a liquid um, biological Band-Aid that hardens after a few seconds. The Babe graft, that's the sticky bone that was presented when I was grafting the ridge, where I used the patient's autologous blood and spun it down in a centrifuge to create this putty type graft complex. So that's using the patient's blood. That's not the periacryl. So
Okay.
I'm using the patient's blood mixing with the particular graft material to convert it into quote unquote sticky bone, as a lot of people may know it as. But I call it the Babe graft because we have all the autologous growth factors and the cytokines. So that's why I call it the Babe, which stands for biologically activated bone enhancement graft complex. So there's no periacryl in that. After the surgical procedure is where I'll use the periacryl over the wound, over the suture line and so forth. So that's where we use that.
Great. Very interesting. Great. Thank you. See what else we have here for you. When you place the bone graft in the tunnel,
Yep.
You don't need to make an opening in the cortical plate for blood supply.
So a lot of times when I'm grafting in the maxilla, because the bone is more cancellous, I don't really decorticate that much, and um, I'm not decorticating in the maxilla that that much. Also because the implants were pretty much really contained in alveolar bone, so I'm really just trying to increase the width, just to give it some more buccal bone thickness. So we get some good blood supply from the periosteum, from the alveolar bone itself. So I didn't really need to really decorticate. If I'm doing a large GBR, if I'm doing some really ridge augmentation procedures, in lieu of placing implants for a future date, then I'll decorticate at that time. But something like this, where I'm kind of doing some onlay grafting just to kind of bring out some bulk, I'm not really decorticating those areas, and not necessary due to the tunnel.
Great, thank you. The doctor also thanks you for the answer as well.
Sure.
Perfect. Let's see here. What is the turnaround time to receive a surgical guide?
It's actually pretty quick. And as with any procedure or company that you're working with, they do have rush service available. But certainly, once the planning has been completed and approved, fabrication of the guides is actually pretty quickly. So within, I'd say, even a week, you can probably get a surgical guide fabricated and completed. Because once it's approved, and now with technology, with 3D printing and so forth, they can get these out within a matter of, say, 24 hours or so. So depending on the type of guide you're looking to fabricate, how large of a quadrant or arch it may be, within a day or so, I think these guides can be completed and fabricated and then shipped out. So it's a fairly reasonable turnaround time. In the past, we used to have to wait weeks and weeks to get some of these guides, but now with the advancement of technologies, we're doing things much, much more rapidly. So it's definitely been a game changer.
That's great. Great for us and the patients, right?
Absolutely.
That's awesome.
Absolutely.
Let's see here. Do surgical cases always have to be flapless?
No, but as I mentioned in the presentation, if I can and if we have adequate keratinized tissue, I try to keep it to doing it flapless, just so I can keep the case minimally invasive. Anytime we go and raise flaps, there's more pain, there's more swelling, more inflammation. So I try to keep my cases minimally invasive if possible. So if I can do them flapless, I like doing them flapless. But if I have to raise flaps, I'll raise the flaps. But certainly understanding when we do raise flaps, there's going to be more, post-operative complications, possibly, pain, swelling, and so forth. So I try to just keep things minimally invasive. It's much more comfortable for the patients, and it's also much easier for the clinician as well. So, when the cases can be done flapless, we do them flapless. Otherwise, we'll raise flaps.
Great. Thank you. How do you determine angulation of implants to the sinuses, and what is the maximum angulation you can tilt implants?
That's a good question, and you're seeing a lot of cases today where you're seeing, the old all on 4, all on 6 types of cases where those distal implants are really angulated, right, to avoid anatomical structures, the sinuses, the mental foramen. So you're seeing these implants angled almost 45 degrees or more in some of these cases. And so I think, I don't know if there really is a set number in terms of angle capacity. I think as long as we have good distribution of our implants, good cross arch stabilization. I've seen cases where some of these severely tilted implants, they work. They're still functioning in the patient's mouths, and so I think there's still some research that still needs to be done in terms of trying to give that a numerical value. But I think with cross arch stabilization, distribution of implants, number of implants, there's a number of different factors that go into play. So I would say, at least a minimum 30 degrees is certainly feasible, even maybe up to 45-degree angulation of these posterior implants. But certainly, I think it's better in larger full arch cases where we have flexibility with the angulation of implants.
Great, thank you. And this looks like the last question, actually.
Okay.
How much more costly is it to do guided surgery?
That's a good question, and a lot of people, I would think, assume that it's much more costly. But if you really think about the case and the benefits and what you're gaining from doing these cases with a surgical guide, you'll probably be more productive because in actuality, you're going to spend less chair time. You're going to have less visits, less postoperative complications if everything's planned smoothly. So, in the long run, I think it's actually probably more cost effective because we're planning the cases ahead of time and the initial cost of these surgical guides, and it's really not quite that much more expensive. In the long run, I think we gain because we can have our cases performed much more efficiently. So time factor, comfort factor. I think that's something that we can gain by doing guided surgery. And so I think there's a lot of benefit with guided surgery. Certainly, there's initial planning and that initial cost factor, but some clinicians, what they'll do is they'll pass the cost on to the patient, saying, your case is going to cost X amount of dollars, and if you want me to do this as a guided case, we'll just charge you extra for whatever the lab cost is for the surgical guide fee. And a lot of patients, they're willing to accept that. So I don't think it's that much more of a cost factor, and we shouldn't really let cost really come into play when we're doing our cases, right? So that's just I
Right.
think an added benefit I think that we can really give to our patients.
Makes sense. Great.
Yep.
Great. Thank you so much. And that was the last question. So I just want to thank you so much. It was really excellent, and appreciate
Thank
you
you.
being here.
Sure. No, it's always a pleasure, and I'm always learning as I do cases, as I go back and review cases. So I enjoy doing these programs, and thank you again for the opportunity and for the invitation, and hopefully we'll continue to be doing some more of these programs.
Absolutely. I think we have some stuff in the works from what I understand. So everyone
Very
out there,
good.
be looking out. Dr. Kim will certainly be back very soon with some new cases. So thank you so much, and I'll see you soon. Actually, see you in a week time for
Absolutely.